Good afternoon, everybody. We're going to be going ahead and getting started. So I have the great pleasure of introducing our speaker today, Dr. Jeremy L. Warner. He is Professor of Medicine and Biostatistics at Brown University. He is Associate Director of Data Science for the Legarreta Cancer Center and Director of the Brown Center for Clinical Cancer Informatics and Data Science. His clinical specialty is malignant hematology, and he practices at Rhode Island Hospital. His research interests are in looking at the structured and unstructured data in electronic health records and clinical knowledge bases to improve outcomes for people living with cancer. He is the Chief Technology Officer for hemonc.org, which hosts the largest freely available wiki for anti-cancer regimens and its derivative hemonc KB. He is one of the co-founders for the COVID-19 and Cancer Consortium and directs its Research Coordinating Center. He is also editor-in-chief of JCO Clinical Cancer Informatics. Please help me give a warm welcome to Dr. Warner.
Thanks so much for having me. And depending on how this goes, maybe you'll invite me back or maybe you'll never want to see me again. So we'll see how it goes. All right. So let's see. This clicker is actually not working. Maybe I have to turn it back on. I can use, oh, there we go. Yeah, and I can use the arrow keys. Can you all hear me okay? Is the mic working? Great. Okay. So here's my requisite disclosure slide. I think most of this was discussed in the intro. I do have ownership of hemonc.org LLC, but that has no monetary value. So I feel comfortable talking about it in this venue. Okay, so this is this is what AI thinks who I am, right? So I think actually maybe the more I stare at it, the more I'm like, actually it is me, but maybe not. And I suggest if you've not heard of it, there's something called the uncanny valley, which you can read about on Wikipedia. If you have an attention span similar to mine these days, this is it. This is the takeaway, which is that we're confronted now with artificial intelligence as, you know, there's a lot of promise to it. It is a technology, and technology does not guarantee success. And this is like a lemon shooter, and this person's making lemonade as fast as they can out of the lemons, but at some point you cannot keep up. So I think the cartoon kind of summarizes it. And then I'll get into some of the aspects in the upcoming hour. So, like the intro said, I'm a hematologist. I treat cancer, and you know, our goal, I'd say, what do we want to do to understand what's happening with people with cancer? We need to somehow measure and understand what we call the full cancer journey, and for all patients. And I'm going to intersperse this talk with some AI images. This one in particular was from 3 years ago, and I'll just say, you know, it does okay. There's some oddities, right? The longer you stare at it, is it really a road? Is it a journey? Is that snow in the desert? What's going on here? But I'll say this. So how many of you cared for people with cancer at some point? All right, so I think you know that the road is almost never predictable, and you kind of think what's going to happen, and that doesn't happen. Number two, AI is imperfect and still in evolution, as this image shows. And then I think, I won't dwell on this, but I think the idea that we're going to measure every step of a cancer journey implies that someone has to lose agency, in particular people who may not want their journey measured. But that might be a discussion point later. I will say, I went back to AI and I generated a new image, and this is ChatGPT in 2025, and I have to say it's impressively better. So AI is definitely improving, even month to month, year to year, for sure. Okay, so what is this cancer journey I'm talking about? I actually think of it really importantly as two separate but intertwined journeys. Okay, so the top half there would be what we hope is the common scenario, which is in a cancer is diagnosed early and it's curable. And in that kind of scenario, we have opportunities to assess risk. We have opportunities for prevention and early diagnosis. I'm sure if you haven't had it yet, you'll have a talk about multi-cancer early diagnosis testing. And then we have a sort of intense period of treatment and then a quick, hopefully, pivot to surveillance and survivorship. The bottom journey there shows what's the incurable or advanced or relapse setting where sure there was an opportunity for prevention and diagnosis, but then we're sort of into a treatment mode, as well as a palliative care and eventually end of life mode. So those are the journeys that when I think about cancer, I also think, like I said, these are interconnected. And certainly you can have, unfortunately, a situation where someone's sort of in that top journey and they get into the bottom. I will say increasingly, especially in fields like lung cancer, Dr. Lopez, Dr. Johnny, that there is the potential to go the other way in this journey, which is great, especially with immunotherapy. But the other thing about the journey is that it is a treatment journey in that incurable setting. So you've got lines of therapy. You've also got a lot of toxicity that's happening with treatment. And importantly, you've got later toxicities that we call sequelae. And then you've got really late toxicities, which we call late effects. So all of this kind of plays into when we're thinking about how we're going to bring in AI and other interventions, how we represent this journey. This is another way we've represented it. This is, I think, worth reading this paper if you have a chance. We published this last year. That is a commissioned article for a lay people, which I think is honestly great because I think it gives us all a chance to step back and explain kind of what the concepts we're trying to talk about here for a broader audience. And so in this depiction, you've got a journey kind of going around the outside of the figure, from prevention, screening, diagnosis to treatment, monitoring, and eventual outcomes. And in the middle of this figure, you've got sort of all the new technologies, the measurements that we can do with wearables. You've got new lab tests such as circulating tumor DNA. You've got genomics. You've got advanced imaging. And you've got AI, and kind of all that's coming in and changing the way we think about the cancer journey and the way we measure it, and the way we bring people through it. All right, so I'm going to spend just a few minutes here talking about people, process, and technology, which is sort of the holy trinity of informatics. I was surprised when I did some research for this talk to discover that this idea is not at all new. It's from 1965, okay? And actually, when it was first described, it was in 4 different ideas or concepts, and it was simplified later to people, process, and technology. And I want to spend some time on that. Okay, so first, what are people, right? what are we, right? So, and I won't spend time on this, but before we get to the other stuff like AI, it is worth thinking about what we are. This is the best I could come up with. We are embodied, right? So we're physical. We communicate. It's hopefully what I'm doing right now with you. And we're autonomous, right? And these are not people, and they're not cats either, by the way. But if you look closely enough, you'll be like, what is happening there? What are those things? Don't look too closely. All right. What is process? Process, simply put, is doing things, right? And I like to think about that sort of a little bit dichotomously. We can do things the right way, and we can do things the wrong way. And let's get into that a little bit more, okay? So if we do things right, that can help. That can lead to benefit. So the example in our field is a curative therapy that works. Doing things right can make no difference. An example of that would be giving immunotherapy when it's indicated, but it doesn't do anything. It doesn't work in that particular patient. And then, as I alluded to earlier, we can do things right, but we can still cause harm. And in our field, that would be the sequelae and the late effects, the toxicities that we deal with every day. We can also do things wrong. What does that mean? Well, if we do things wrong and it hurts people, that would be called we'd all call that a medical error with a consequence. I think most of the things we do wrong in medicine actually don't make a big difference, and we call those near misses or opportunities for improvement. And then occasionally we can do things wrong and it actually leads to a benefit. My favorite example of that is a drug that we use in hematology a lot called bortezomib, which was an intravenous drug that caused a lot of neuropathy as a side effect. And then completely accidentally in a clinic in France, extravasation event. So they thought the IV was in the vein, but it wasn't. And the drug ended up in the soft tissue. But the patient was okay. And not only that, they stepped back and like, wait a second, maybe this is a better way to deliver this drug. They undertook a phase 3 trial. They actually showed it was equivalent to the IV route and caused less neuropathy. So that mistake led directly to a new route of administration with less toxicity, and certainly patients prefer receiving a drug subcutaneously than intravenously. So that's an example. Now, can you see there's a little small on the bottom there, but I want to make an observation, which we'll get back to at the very end, which is this is 6 different outcomes, right? Like, so three right outcomes, 3 wrong outcomes. Our collective expectation of how the day-to-day practice should break into these pieces is very different for humans than for machines. And we have to think about, what do we expect from ourselves as far as doing the right thing, doing the wrong thing, and what is okay when it comes to a machine-generated output. All right. Have any of you been to Nashville, Tennessee? Yeah, next time you go, check out this museum. It's called the Lane Motor Museum. They actually have a collection of these vehicles, these technologies, which this one actually works. That's someone driving it. I don't think you'd want that in front of you, right? Especially if you're not a pedestrian, but it actually works as a technology. That's a propeller, in case you can't tell, that was actually sucking the vehicle forward. And so there's a whole set of vehicles like that. Okay, so what's our technology? The EHR, right? Let's talk about this thing. The electronic health record. How many of you have used an EHR? I think everybody should raise their hands. That's just to check if you're awake still. And so, there are people out there that have done a lot of thinking about what is an EHR. And this is something, and I'll get back to this, this box here. This was a report from 22 years ago, kind of laying out what are the primary and what we call the primary and the secondary uses of an electronic health record system. So one thing I want to preview for you, though, and I think you know this as well, as users and creators of EHR products, is that, we all talk about unlocking the EHR and that there's treasure buried in there. And there is, to some extent, and AI can help us find that treasure. But there are whole areas of humanity and human experience that are not going to be found in the EHR usually. If I just, can you see the mouse moving around? Yeah, maybe I'll just not worry too much about it. But, basically, this little table here shows you that, we often find things on the left on that table in the EHR and not on the right. So I'll just, first do, we're going to find a date of birth for every patient, but we're not going to know too much about the place and circumstances of their birth, most likely, unless they're sort of in that system the whole time. We may know their biologic sex, but we're not going to know their gender orientation or sexual identity, and onwards. For us in cancer, the most important are the last two. We might know what happened, but we don't know too much about the burden of treatment and the toxicity of treatment, nor do we know too much about the response to the therapies in the EHR, because it often doesn't get documented as well as it could. If you don't believe me, here's a paper that came out that looked at this actually paired surveys. So they asked patients, are these social determinants of health important to you? And then they looked in the EHR to see if they were documented. And I'll cut to the chase. The blue bars are the patient's responses. So, for example, this patient, 38% of patients reported a financial resource strain. And the yellow bars, can you see them, right? That's how often this actually showed up in the EHR. And I think this is about as stark as it gets, right? So I don't know if we need to do better or if we need a different way of documenting these things. Maybe that's not the point of my talk right now, but I do want to definitely show you that there are these major gaps in information availability that's going to affect anything we do downstream, such as AI. All right, so that having been said, I like to walk through, this is what I call the brief history of medical records, not EHR. We'll get there. This is medical records. I'm going to go through this quick. Do you all know that the first medical record was from 3,500 years ago? That's true. That's it. In the middle there, it's the Edwin Smith Papyrus. And that actually went through a series of cases and what to do about it. And if any of you read the Emperor of All Maladies, have you read that book? Yeah, it's a great book if you haven't. He talks about it in there. And, basically at that time, 3,500 years ago, the treatment for cancer was, there is none, right? Like that was the treatment, but we've evolved. But didactics, teaching, case records, teaching people what to do in a scenario, that was the main purpose of the medical record for thousands of years. I would say that the next main or major purpose of the EHR or the medical record and now the EHR is a legal purpose, which would be to document what happens in the case of something like a medical malpractice lawsuit. Because if you think about what happens in the absence of documentation, it's essentially one person saying another person did something and he said, she said kind of thing, right? And often these things happened years or decades before the lawsuit. Because of documentation and medical records, I think primarily, 60% of liability claims against doctors are dropped. And then if they go to trial, the physicians are found not negligent in greater than 90% of cases. So this is a major, major use of medical records. All right. This might be the wrong audience for this question because not too many of you are doing billing yet, I assume. But okay, audience participation time. Which of the following has never been a physician payment model? And you can just call out the answer you think is right. I think you got it right. I think this is the first audience that actually got it. You are correct. Medicinal liquor. Nice job. Yeah. Never been so you said nobody called that decapitation because I think you maybe know already that that was a physician payment model at one point. Actually, in the court of Confucius, if you didn't get the emperor better, you had to pay with your life. So that is an interesting model, which I don't think any of us would sign on to now. When you think about billing and kind of how we get paid and whatnot, believe it or not, until what I say recently, maybe within the lifetimes of some of us in this room, physicians were paid with food and lodging. Maybe not any of us in this room, but it wasn't until 1965 really that it kind of started to change, in that there was this new idea called the physician fee schedule based on usual, customary, and reasonable practice. And that's kind of what led to additional rules, additional regulations, and kind of the world we're in now, which is this CPT code-based world where we do these things and we get paid to do these things. It's the fee-for-service model that we live in. I keep this. This has now been superseded by some simpler rules, but I keep this to illustrate that how are you going to prove you did any of that? If there's an audit or something, it's your document, right? Like it's your documentation that proves that you did your review systems, that you thought about the case, that you did your medical decision making, and so on and so forth. And so that's another major use. Now, I on purpose I'm saying this one last, which is patient care. Obviously, we all think the medical record should be there for patient care. And that whole idea kind of came about over the past really 100 years. And what, the fact that fascinates me is that in 1918, okay, fewer than 20% of physicians kept any records at all, okay? And it was actually the American College of Surgeons who mandated hospitals to start producing discharge summaries, which we all know and love. And to actually talk about what happened during the hospital stay and the outcomes of that hospitalization. And then it was some other kind of innovators like this guy at the Mayo Clinic who introduced things that we all know very well, like the medical record number, the chief complaint, all these kind of things that we take for granted now. I love throwing in this quote here. This is an actual treatment from the case records of the MGH. Twice daily doses of mercury, boiled milk, and lime water, along with a carrot poultice. I don't know if we're going to go repurpose that one anytime soon, but all right. So, so another aspect of documentation until recently was this whole thing. So this is called the casebook. I'd love to, I haven't seen too many of these in person, but this was, for those 20% that did keep notes, this was the main way they kept them. And it's a diary essentially for the doctor, not for the patient. So it's sort of period, by date. And so they would go back and remind themselves of what happened. But it certainly wasn't patient oriented. So has anybody heard of the problem-oriented medical record, which is kind of how we live now, right? The new idea, right? This was a new idea. In 1964, this was sort of a brand new idea that was introduced through a series of New England Journal papers by someone named Larry Weed. And he came up with this structured approach where you talk about symptoms, you talk about objective findings, you talk about a plan or prescription, a prescription, and then a plan. So do you all know what that is? The SOAP note, right? Like the SOAP note. That's what we live. Now, I think sometimes we document a little different, to slightly different order. Couple of things about Larry Weed. So one thing in his initial publication in 1968, he saw what was coming, and it's worth reading this quote out loud. It can be readily seen that all narrative data presently in the medical record can be structured, and in the future, all narrative data may be entered through a series of displays, guaranteeing a, et cetera. This was before electronic medical records, right? But he was sort of envisioning that this is what's going to happen. My favorite part of this quote is the bottom where it says "to be concluded." So that's from, okay. So he actually created this, okay? And this was actually implemented at a clinic in Maine. I forget the name of it, but you know, they had this 100% structured medical record. All right. What is it? Does anybody have an opinion about this? Or, you know, what would you think about this if you had to do this? I don't know, right? Like, so first of all, it's a lot of check boxes. By the way, the nurses have to do, like, it's close to what they have to do, right? People have done research on how many clicks a nurse does in a day in the hospital, and it's thousands, right? The other thing about this, though, is that while it's structured, actually, there's a lot of still handwriting, right? So if you think about how are we going to digitize this, how are we going to use this for AI, it's actually not so simple. This failed, right? This did not go beyond that one clinic. Okay, audience question number 2. What does EHR stand for? I'll let you read the options. It's multiple choice. What do you think? Oh, none of it? It's close, but all of the above, all of the above. These are all EHR. Okay, so in particular, Microsoft Office, right? So I first noticed this in 2014 personally, that when you type EHR, it turns it into her. And it still does it. And it's a screenshot with it. This is with Copilot, so it's like AI, advanced AI. And it just still did it. And it said, and then I said, please, you know, fix that. And it said something went wrong. So there you go. All right. Going back to that, what I showed you a couple slides back. What is an EHR? So this is how you kind of think of these primary uses, secondary uses. And I agree with this. But again, going off what I just talked about, patient care and billing, those are considered primary uses. Legal and didactics now are considered secondary uses. And I'd argue kind of AI and doing things with AI and knowledge representation is a secondary use. That doesn't mean it's not important, though, right? So just like those things. And for me, the most interesting part of this whole story is that didactics have gone from the primary use over thousands of years to now it's sort of, you know, afterthought sometimes. Okay, I'm going to do an even briefer history of AI, and I'm going to move on to the next topic, which is that the EHR, the electronic health record, and AI have actually evolved in close parallel. The very first EHR was introduced around 1950, which is the same time that the Turing test was invented, which is sort of the beginning of AI. What's really interesting about AI is it's been through these two, what we call winters, like prolonged periods when the public the hype broke, like the whole thing, and the field as a whole, including the very methodologics parts, hit a very deep, bleak winter. There was a boom times in the 80s, I think, for AI, and we're definitely in a boom time right now, right? And along this scale, also EHRs came into their own. And this deep learning revolution with ChatGPT and all that, that actually started probably over a decade ago in 2012, and is continuing apace. All right, I'm going to change gears a teensy bit here, and I'm going to talk about why it's so important to have what's called interoperability in cancer care. Is everybody familiar with interoperability as sort of a concept or general? I see some shaking heads. All right, so Actually, okay, this explains it. Okay, so now it's one thing when you've got a large integrated system like you all do here with like, if you have full capture of your patients and everything's on the same EHR and all the data is on one data model, you're good, right? That's just not the case in most scenarios, and probably including here. Even if you think you have one integrated system, you may or may not, depending on how how software's gone live over time and all this. So this is a slide that I hope drives this home a little bit. So I live in Providence, Rhode Island, which is sort of right at the edge of Massachusetts. Rhode Island's tiny, but it's kind of self-contained. And what you might have is a patient who lives in Southeast Massachusetts, who has a local doctor. They get diagnosed with some kind of cancer, so they want to come to the closest major center, which for them, it's actually us in Rhode Island. They want to get their surgery. They want to get some medical oncology work. If they need radiation, though, they might want to go the other direction because of traffic and whatnot, so they might end up in a different system for that. And then they've got friends and family and other caregivers that are kind of scattered around the region. And what you get here is the need for interoperability, which is, can the data about that patient pass between these different settings without getting mangled, essentially? So it makes me think about this, which is, we all live where there's a lot of geographical localization to our experiences. And I guess if you live here, you're supposed to recognize the backdrops of Miami Vice. All right, so I felt like I needed to watch Miami Vice as homework before I came and gave this talk, but unfortunately Netflix did not offer it. So sorry, it's a little bit before my time. All right, so and geography matters for all kinds of reasons, right? And I could spend a whole talk on this, but here's an example of how people voted in the 2024 presidential election and their rate of COVID vaccination. And if that's not a clear correlation trend for you, we got to have a discussion. I do have that biostatistics title, but don't push me too far about that. But all right. So what did we do? So we did this. We did this kind of. It wasn't unauthorized, but it was a little controversial, actually. We did this calculation of how consistent are the variables across EHRs. And we worked with my professional organization called AFFILIATIon, which had created this big thing called Cancer Link and was bringing in data from all over the country. It actually had 68 sites participating in this study. And we asked a kind of a simple question, which is both within a vendor system and then across vendor systems, does the information flow? Does it match up? This heat map will show you that to the major extent it does not. And I'm going to zoom in here. So across these 68 sites, there were 5 vendors. This project took many years because the vendors were so, they didn't want to be named, okay? And you can see why, right? So we couldn't do this project until we figured out how to mask them. And we couldn't report them except as A, B, C, D, E. You can see that within a vendor like B2B, the data agrees 93% of the time, and E to E, it's 98% of the time. But then, even within certain vendors like A, it's only a quarter of the time that the data could actually flow. Gilberto's like covering his eyes. And it's really bad. Like, look, vendor E to vendor C, 1% of the data actually matches up. That's horrible, right? And then overall, only a third of the data elements. Now, before you say, or you might say, oh, you were looking at fancy things, I'm sure, right? Cancer, fancy stuff. This is what we were looking at, all right? Acetaminophen. Can we, match that up? A few cancer drugs, sure, but they're common drugs. This is not, sort of like the rare things. And then some lab tests, which I think we all think hemoglobin, should be something that is universal, right? It's not. It was just amazing to us, like the low level of interoperability that we currently have in this country. And this was 3 years ago old, but if we did this study again, which would be really difficult, by the way, but I'm not so sure that this has gotten a ton better, but maybe it will at some point. So this is part of the issue, is that when people are left to their own devices, they they come up with all kinds of solutions that are not necessarily going to match up, even if it works for them locally. And so this is an example. We looked at 5 institutions. Again, I've masked them. I don't want to reveal. I do know that some of these are not all US based. Some of these are in Australia and elsewhere. And you can see that institution D and institution E have chosen a universal representation for medications in their system, but it's different, right? One is the purple choice, and one is the green choice. But then institutions A, B, C have all kinds of different representation for medications. And so this is just illustrative, again, of the challenge we have when we want to try to mash up data. And is anybody, okay, well, maybe I'll get back to that. Okay, so let's just go to free text, right? Let's just forget all those coded things. And so here's a problem. It just happens to be a drug that you probably prescribe a lot of it, right? Well, maybe not anymore. Maybe it's osimertinib now, but which is maybe easier to spell. These are real spellings of this drug in the Vanderbilt medical record that I found. It's sort of a little pet project, which I was amazed by. This is all real. The oncologists in the room can kind of know which drug this is, but can ChatGPT? Actually, yes, it can, right? Like, so that was impressive, right? So I gave this, or this is Gemini. So I gave it this table and I was like, what drug is this? And it's like, erlotinib, right? So I was like, wow, okay, we have the solution maybe. I'm going to skip this slide. I am going to say, I like to pitch this effort called USCDI, which is stands for United States Core Data for Interoperability. And this is an effort to get those vendors to actually implement standards that will lead to an improvement in that interoperability issue. I'm personally involved in something called USCDI Plus Cancer, which is a mouthful. But the idea here is that federal partners, some controversial words on the slide, right? The moonshot, et cetera. But the idea here is that federal partners are going to come together and tell the vendors, look, you really should represent these cancer-specific elements in a consistent way so that we're not dealing with 100 misspellings of erlotinib. We can actually join up data and do some cool things. And so what are those things? So these are some examples. These are the first 4 use cases in that endeavor. One is the enhancing oncology model, which is an alternative payment model in oncology. The other is cancer registries, which gather data from at the state level and then the national level to understand the incidence and changing incidence of cancer. The other is clinical trials matching, which is so important. You can imagine a patient comes across institutions, gets some care, I don't know, somewhere else, and then wants to come to Miami to get their phase 3 trial or whatever have you, or their IIT. And then the other one is a little bit more site-specific, but it's immunotherapy-related adverse events. So these are the first 4 use cases. By the way, USCDI plus cancer is optional for the vendors, which is never great, right? When you give someone an option, are they going to do it? However, the big ones, and we won't say them out loud, but I think you must be on one of the big vendors, I'm sure here, have at least said that, okay, if you make it so, if you roll out these guidelines and standards, we will do it. So we certainly hope that that will happen. And since this is general medical grand rounds, I do want to say that I think hopefully you see that there's extensibility here beyond cancer. And there are other USCDI plus efforts like in rheumatology, rare diseases and others. So keep tabs on it. All right, so now I'm going to actually change gears and talk about our work on what's called the HemOnc knowledge base, or the HemOnc KB. Remember this picture? Because I'm coming back to it in a minute, okay? Does anybody know what that is, by the way? Is anybody from the Midwest? Because you might know. It is, but look closely, right? Like something strange, right? Anyway, we'll get back to it. All right, so to introduce the knowledge base, I'll quickly mention our website, which kind of drives the knowledge base, which is hemonc.org, which we aim to capture all standard of care systemic anti-cancer treatments. So that's the drugs, the immunotherapy, and et cetera. Less so the surgeries and the radiation, although we have some of that. We have a lot of content on this website, over 1.5 million lines of content if you actually want to count it up. Over 10,000 references, 5,000 regimens. It's a big, complicated space. And our content has just kind of grown and grown over time. We get visitors from all over the world. This is a heat map of visits over, I think, the last year or two. So we get about 25 to 35,000 visitors per month. And I had to add this little footnote. Those are humans, we think. No, we know those are humans. We've had actually a big issue lately with bots. And maybe I'll talk about that later, but I don't want to talk about the bots, but it's actually becoming a big, we literally get 10 times the traffic from bots that we get from humans. We work closely with something called Odyssey, which is the Observational Health Data Sciences and Informatics Group. And they have this simple idea here, which is, okay, and as I was just talking about before, like you give different institutions the choice, they're going to come up with different solutions. And so you might have like the lilac, the purple, and the beige. Those might be 3 different institutions, 3 different EHRs, 3 different whatever have you. The idea of Odyssey is that you do a transformation, hopefully simple, to get things into a common model, and then you can do analysis across hundreds or even thousands of sites. Odyssey has over 1 billion patients in their database, if you will. And so they can do some massive, really interesting projects looking at kind of all kinds of ideas across medicine. So we work closely with them in the oncology space. This is our data model that we've developed in collaboration with Odyssey. But instead of dwelling on this, I'm actually well. First of all, I want to show you that this comes from our website. So here's a screenshot of a regimen, and each piece of this regimen kind of goes into that model. How many of you are familiar with sort of ontology, like as an idea, as a concept, and how it works? Good, because okay, so I'm going to just do a little bit of didactics here about ontologies, because I think this is what we have that AI does not necessarily have. Okay, which is this. It's a formal, explicit specification of a shared conceptualization about something about the world. Okay, and it's composed of what we call components. So typically, you have what are called concepts or concept classes, which are groups of things, and concepts are individual examples of those things, and then relationships actually link those things together. I think this is kind of simplistic, but actually pretty much covers it, right? So this is how we can represent whatever we want to represent. This example is something called the pizza ontology. So I'm going to just walk you through that a little bit. So, so when we put those things together, we call it a triple. So, it's, if you subject, verb, object. So the example here is a pizza has a deep pan base. Pizza is one concept. Deep pan base is the other concept, and the pizza has the base. That's the relationship. Why is this a good thing to do? Because it's precise. You can this is a cartoon, which actually like illustrates the point, right? Well, hopefully no one's gonna do this, but actually when you label things like this, you can build up a shared knowledge of the world and how it works. And then you can undertake work like what Odyssey does with distributed analysis. So just to get into that a little bit more, so here's that pizza example. In pizza, you've got the whole thing. It's a pizza, and you've got the bottom, the base, and you got the toppings. And with those 3 kind of classes, you put it together, right? And so again, those relationships is everything, right? So pizza has a base, pizza has a topping, like a mozzarella cheese topping, it has tomato topping, et cetera, and you can build up your model of the world. You also can restrict what's possible, and that's really important for when you talk about ontologies. So in this example, you say a pizza must have a base, and the topping can't be under the base. So now we get back to this picture. So this is actually like an upside down pizza. Right? So this is something that I discovered is only eaten in one part of Michigan or Wisconsin or something, I don't know where. It violates the rule. However, it's okay, right? Like as long as you sort of have the world that you expect to see, you can handle cases that don't fit. And in fact, those can tell you new knowledge about pizza, right? And then you can go back and you can change your model, expand it, and what have you. All right, so that's kind of how we approach this, and so we've built up this fairly large knowledge base. We've connected it with outside terminologies, which I don't need to dwell on. We have additional tables that represent things that are not easily represented, such as clinical trial results. And also, we spend maybe too much time characterizing clinical trial lists and where they come from, what kind of work they do. And so, Gilberto, I'm really glad you're here because there you are. Okay, so I was like, okay, can we? So I'm going to ask you all, does this have face validity? Because this is coming out of our knowledge base. We found 80 investigators that have been involved in some of the most important clinical trials in the cancer space. I don't know if this is right. Hopefully it is. Some have left, yes. So I'm actually glad you said that because I want to brag that our knowledge base goes back to the 1940s. And so I would expect that maybe some of these folks have left. Yeah, so you can do a lot of different things. And I guess I don't have time today, although I'm going to end with some time for questions. I don't have time to talk about things we've done like social network analysis. We've done work on gender and representativeness in oncology, career trajectories, what drugs people study and maybe why, the success rates of trials. Do those relate to the people that conduct the trials or the drugs and or both, right? So these are kind of questions that we can start to ask as we've built up this knowledge base. I do want to advertise it to you if you are interested in this. You can download it. I think everybody here is an academic user. You can get some of it through Odyssey. That's the link on the left. Or you can actually download the whole thing and play around with it through something called the Dataverse. If you just Google HEMONC Dataverse, it should get you to the download. But I'll send these slides out to you. Okay. LLMs. Can't do a talk about AI without talking about LLMs, right? So, and I like that. So I just have fun, right? Sometimes like giving some prompts and seeing what happens. So this prompt is give me a big old large language model, and this is what I got, which is a big old something. I don't know, but it's kind of neat. All right, so this is and it's not on my slides, but time for another audience interaction. How many of you have used open evidence? Wow. All right. That's quite a few. And have you had any hallucinations or other problems with it? Yeah. All right. So, all right, let's talk about that for a second. So we actually, we were worried about that too, just sort of generally speaking. So we actually undertook a study, which I'll tell you about, where we did kind of a blinded trial where we measured several different metrics of LLM output, not just hallucinations, but 6 different things: accuracy, completeness, relevance, clarity, coherence, and hallucinations. And in summary, that's sort of a measure of quality, right? And so what we did, our task was kind of, I think, what open evidence does as well, just summarize the clinical evidence and present it as a synopsis. And we compared, at that time, it was about a year ago, the 4 leading commercial LLMs, Claude, ChatGPT, Gemini, Llama. We prompted them with the same, with a prompt about multiple myeloma and amyloid treatments, 6 different treatments. And then we had 2 hematologists independently and blindly review these results for these axes. So. And this is what we got. And a couple takeaways here. One is they are different, right? So what we found in this study was that Claude was the highest performer and Llama was the lowest performer. And those differences were pretty big for certain things like completeness and accuracy, and statistically significantly different, right? But also, none of them did great. Like all of them had issues in all 6 of these domains, to the point. So this is Likert scales, and like nothing gets up to the very clear, perfectly accurate. Nothing gets up to that level. And this does get back to my kind of grounding question, which is what is the error rate we're willing to tolerate in these things? But we felt like our conclusion on this was that none of these were really ready for prime time, but there are differences. And so that gets into like, which one do we trust? I will tell you, my colleague has done this with open evidence, and it does worse than any of these four, by the way, on his task. But I think it's a nice user interface, right? So that's sort of, okay. All right. Here's a few more things to think about. Someone has now come up with the DSM for LLMs, okay, which is that they have a bunch of error modes and psychopathies, if you will, and they've created this this sort of conceptual diagram of the different psychopathies that the machine has, and the risk that those pose to us as doctors, and I suppose eventually us as humanity, right? So it's kind of ranging from relatively low risk issues such as the top one here. This would be the hallucinations, synthetic confabulation. It's not probably super high risk. But then, you know, the machine, ubermental ascendancy, like the machine becoming convinced that it's more important, you know, more important than humans, that could pose a high risk to all of us. Okay. All right, so let me stop and open this for questions. So there's a couple of takeaways from what I just talked about. One is AI in general is a technology that will only succeed within that larger organizational context of people, process, and technology. So we have to think about how we implement it, how we measure success or failure. And by the way, I have to throw in that the development and use of these tools requires a lot of energy and has huge environmental impacts that we have to think about. Number two, as physicians, our collective expectation for the distribution of harms and benefits, again, is very different when it comes to human error versus machine-caused error in particular. And then lastly, knowledge representation, I believe, is critical for reproducibility and testing, even if the LLM outputs make sense in particular. Thank you very much, and I'll pause for questions.
Thank you, Dr. Warner. That was really provocative and interesting and entertaining. Thank you. All those things were hit. It seems to me, though, in medicine, just as our medical students tend to anchor in a diagnosis, all of this sort of comes down and anchors in a diagnosis, and then everything else sort of like feeds into it. Where are we in terms of getting the diagnosis right, which then other things may fall into place? Or is that not a concern at this point?
So, so I think, well, okay, so how do I want to answer this? Okay, so first of all, in cancer, we typically have the diagnosis when we
think you do. I mean, it's based on the pathologist.
Exactly. Right? Right. So we think we do, but what is even that, right? And so as we learn more about cancer, it gets me into a little bit of an epistemic crisis, which is, can we even group, you know, what we call lung cancer and pancreatic cancer? Is this even a real thing, or is every cancer absolutely individual, kind of like we approach psychiatric conditions? I think that's a crisis because the way we treat cancer is based on aggregate knowledge, right? So all of our trials, everything has grouped like into like. So I think, but as we learn more, I mean, we have to have a similarity metric, right? We have to say, well, this particular group of lung cancers is close enough to each other in whatever, you know, characteristic that we're going to treat them as a group, and we expect the outcomes to be more or less uniform. But again, even when you look at, you know, you look at a waterfall plot in a trial, you look at anything related to the field, some patients respond to treatment, some do not. I don't think we have a good grasp on why that is. And the factors go beyond the pathology and also reach into the distribution of drug, whether we're even getting to the target, whether the patients are even taking the drugs as prescribed, right? So there are many layers to that. I don't know if that.
No, thank you. Gilberto?
I have a very practical question for our audience, being trainees and students and faculty, mostly online. What are the things that you see being the greatest uses of AI in oncology and general medicine today? And what do you see coming in the next 1 year and 5 year horizons?
Okay, so I'd really love it if AI made our lives better. Okay, so that's kind of, and what do I mean by that? Like, let's tackle the burden of documentation, right? Let's return to the roots of why we're even documenting in the first place. And if AI can offload that in some meaningful way, I'm all for it. So I think, have you all, you're probably doing ambient AI scribes, kind of without testing though, right? Like you just rolled it out, right? So,
No,
well, did you prospectively test it?
yeah.
Good, good. Well, that's good. Okay, yeah. So, I mean, I do fear we'll jump into these things a little bit. I left it out of the presentation, but for better or for worse, our society jumped into EHRs based on, I think, a single event, which was Hurricane Katrina, which really pivoted us towards spending billions of dollars on rolling out EHRs. And, you know, it was very well intentioned. People lost, you know, medical records were lost, physical ones, they were swept away, you know, waterlogged and so forth in Louisiana in particular. Well intentioned, but honestly not scientifically implemented, right? We just rolled it out like it came in across the country. And, you know, I think we're dealing with that now. I think we're dealing with the fact that we didn't maybe think it out as well as we could have as a profession, as a group. So I think there's that. I think the question of whether it's going to make so that's sort of our day-to-day, our experience, our documentation, our billing, right? Like, why are we even billing anymore, right? Like that could be offloaded completely. Clinical decision support, though, that's where things get interesting, right? Can we use AI to help us make the best decision? Well, I think we can use it to surface the evidence that we need to make the best decision, but I would caution everybody to not just, you know, go along with what the AI is telling you to do. You always want to trust but verify, right? So that's going to be key. I think there's a case to be made that it could help patients, especially with physician shortages getting worse. Can we actually, you know, empower patients to undertake more of the day-to-day work of what they do without the typical clinic appointment, without the face-to-face, right? So I think there's many ways, but then I'll reflect that question back to you and say, what are you thinking? What are you thinking right now for that?
I think the documentation is certainly something that we're hoping is going to be extremely useful in the next few months to couple years. Beyond what you're describing, and of course, when we talk about cancer, we're talking about primary prevention, we're talking about screening, diagnosis, and treatment. So in each one of those buckets, we have techniques, we have models, we have tools being developed. The FDA has approved hundreds already of AI related, if you will, models and devices. And this is certainly something that we are trying to sort out to see what truly is useful and what is just noise. And I think that may be the biggest issue we have with AI today. I wrote a piece recently using as a metaphor Jorge Luis Borges's Library of Babel, because if anybody has read it, it's a fantastic story in which librarians in this infinite library are looking for the book that can answer every single question. And of course, the book ends before you do any of that. And that's our parallel with AI today. We're trying to make sense of all of the information we have and bringing that into oncology alone. We do have tools that are starting to become useful in terms of aggregating information. And the biggest challenge we have is, as Jeremy and Dr. Weiss mentioned, we have for each patient, we have a very specific set of mutations, of methylations, of changes in their DNA, of course, which are influenced by everything else that happens, where you live, what your zip code is, what you eat, if you exercise or not, and so on and so forth. So today, we are not quite there yet, but I think that that's the holy grail of what we're looking for with AI. Are we going to ever get there? Perfection is probably unattainable, but we hope to get closer and closer to it in our daily lives. What keeps you up at night?
Well, so
AI?
that prompts me to think again back to the great book by Siddhartha Mukherjee, The Emperor of All Maladies, and he has a whole chapter on this cautionary tale of what happened to our field in the early 1990s when more was more was more was more, and we just kept adding on. and created this scenario where we really harmed patients. In the example would be autologous stem cell transplant in breast cancer, which was, you know, a poorly done trial, which I believe was retracted later and then could never be reproduced. But that nevertheless drove the practice to basically treat many, many patients with this very intense treatment, which caused a lot of leukemia afterwards. And I'm a hematologist. I still occasionally see a case of acute myeloid leukemia coming in from someone who had that breast cancer treatment decades prior. So why don't we use AI to de-escalate? That would be my, you know, that would be wonderful, right? Could we, with a lot of confidence, identify the patients that don't need the intensive therapy, and then also convince them that they don't need the intensive therapy? This is such hard work. And I don't know, were you part of this trial that just came out, the David Spiegel's trial with the 14 gene classifier? And I thought that's great, right? Like, okay, so basically it's a trial essentially trying to do with lung cancer what they did with breast cancer, which is to risk stratify patients and say, okay, you know, you're high risk, you should get the adjuvant chemo, but you are not, and you don't need the adjuvant chemo. So I think those classifiers are great, and that takes AI and a lot of, you know, sophisticated stuff to come up with those. For instance, they started with 200 potential candidate genes. And again, if you were part of it, you should speak to it more than me. But, you know, they undertook some advanced analytics to figure out these are the 14 genes. But that, I mean, the other part of that is convincing patients that they don't need the intensive therapy, because I think there's a lot of demand in our society too, that more is more, right? So.
Thank you,
Yeah.
Dr. Warner. That was
Okay,
great.
thanks.
Before we leave, I have some news hot off the press that 2 of our faculty members have been voted into the Iron Arrow Society. Our own Dr. Bland, stand up, show us your coat. And Dr. Sussman also has been elected to the Iron Arrow. This is the highest honor that the University of Miami bestows upon its faculty. So congratulations. I want to remind everybody to check the chat for the QR code in order to get CME credit and MOC credit. I look forward to seeing you all here next week. And in the meantime, take good care of yourselves and each other, and try and come in person next week for those of you on the line. Thanks.
Thank you.